49-year-old Caucasian woman with body mass index of 17.2 with known medical history of hypertension, rate-controlled atrial fibrillation, hypothyroidism, aortic insufficiency, lymphedema, and hypoxia secondary to partial lung restriction at home medications of warfarin, levothyroxine, metoprolol, and montelukast, furosemide, infratropium bromide, and fluticasone, presented to North Shore LIJ Plainview's emergency department at 2:30 p.m. after a witnessed fall not associated with head trauma or loss of consciousness. Her vital signs on presentation were blood pressure of 144/81, pulse of 119 beats per minute, respiratory rate of 18 breaths per minute, temperature of 98 degrees, and oxygen therapy. An electrocardiogram revealed atrial fibrillation at 113 beats per minute, along with bundle branch on left anterior vascular block. At 3:30 a.m., our patient suddenly became bradycardic and progressed to asystole. She was found to be pale and pulseless. Cardiopulmonary resuscitation was immediately begun following advanced cardiac life support protocol. Initial respiratory support with a bag mask was attained, and our patient's trachea was secured with intubation at 3:32 a.m. As per the ACLS protocol, 1 milligram of intravenous epinephrine was given and followed by 40 milligrams of intravenous. Vaspressin given at 3:36 a.m. Our patient received her second dose of 1 milligram epinephrine at 3:40 a.m. Finally, at 4:36, our patient received an ampoule of sodium bicarbonate. Our patient remained unresponsive to continued resuscitation efforts, so CPR was abandoned at 3:48 a.m. Right femoral venous access had been attempted during the resuscitation effort, and cardiac monitors were unwillingly left on our patients during cleaning and removal. At 3:51 a.m., before complete removal of the femoral venous chatter, a single vascular constriction was noticed on the monitor. The single constriction progressed to outlet. The single constriction progressed to couplet, then a triplet, and finally into a normal sinus rhythm with a palpable pause. At 3:53 a.m., her initial blood pressure was measured at 80/50, and her patient was started on neoepinephrine, dripped at 10 through the femoral venous axis. A right femoral arterial line was also established for continuous blood pressure monitoring. Her blood pressure stabilized at a mean arterial pressure of 70, and our patient was transferred to our intensive care unit at 4:30 a.m. In the ICU, a hypothermia protocol was initiated and vasopressors were titrated to maintain a systolic pressure greater than 90. Unfortunately, at 10:55 a.m., our patient went to ventricular tachycardia despite respiration activation efforts. Our patient was pronounced dead at 11:03 a.m.